So good morning, everybody. Today we are continuing our lecture on lung diseases. And then we will start off discussing atelectasis. So I'm now going to share my screen with all of you. Okay, so now we're going to continue on our discussion on atelectasis. So basically, when you talk about atelectasis, there is incomplete expansion of the lung. There is a collapse in the lung. So whether this is compression, maybe presence of fluid that is compressing the lung, making it difficult for the lung to expand, or there is contraction or collapse. So these are different situations wherein you may have atelectasis of the lungs. Then we're going to go into acute pulmonary injury. So I'm going to be posting additional data on atelectasis, which I will want you to watch, additional in-depth video later on. But basically, when you're talking about atelectasis, it is incomplete expansion of the alveoli. So whether this is either compression or there is contraction of the lung cannot expand properly. And a lot of medical diseases may cause atelectasis, may cause a complication of atelectasis. Even simple surgery, abdominal surgery, you may develop microatelectasis after surgery because of difficulties in lung expansion, wherein the patient may have difficulty in lung expansion because of their abdominal breathing. They feel pain, and so they're not inhaling properly. So here you have to instruct them to do deep breathing exercises. And of course, certain diseases, pneumonias, may cause some form of microatelectasis. COVID-19 may cause some forms of atelectasis also. And then, of course, COVID-19 may later on progress to pulmonary fibrosis, but this is another topic altogether. So different things may cause atelectasis, whether there's something, even massive pleural effusion, that is causing the difficulty and compression of the lung to expand. That is, of course, an example. So we'll move on to the next one. So we're now going to acute pulmonary injury. Here we will be discussing pulmonary edema, ARDS, and acute interstitial pneumonia. So let's look at pulmonary edema. With pulmonary edema, of course, you are dealing with increased fluid within the lung because this is usually caused by increased venous pressure and decreased oncotic pressure. So increased venous pressure, there will be more fluid going in. The decreased oncotic pressure means that there is intracellular fluid that is going out. And then you may have lymphatic obstruction and, of course, alveolar injury. These may all cause pulmonary edema. And, of course, you may develop pulmonary edema as a sequelae of other diseases or as a complication of other diseases as well. We'll now discuss ARDS, okay, or DAD, diffuse alveolar damage, or AKA your shock lung. So this will occur when the fluid builds up in the tiny elastic air spaces or the alveoli in your lungs. And the fluid keeps your lungs from filling up with air. So this means that less oxygen will react to your bloodstream. Less RBC will have oxygen. Less oxygen will be distributed to the rest of your body. So this deprives your organs with the oxygen that they need to function. So basically, you're having a form also of a VQ mismatch here. So ARDS is a non-specific pattern of lung injury, and it may be caused by different things. It may be caused by infection, physical injury, toxic substances, or even inhalation of toxic substances, chemical substances, DIC or disseminated intravascular coagulation, and ETC. So this is a slide showing you ARDS. So this is just how it will look under the microscope. It's a sample of ARDS. Acute interstitial pneumonia, think of it as ARDS but with no known etiology. But it will happen that there is affectation of the interstitium spaces of the lungs. Now, looking at the differences of obstruction versus restriction. So let's look at the differences. So here, what will be affected? Okay, with obstruction, air, there's problems with air delivery. Okay, sabihin na natin na in some cases, there is difficulty in removing the air from the lungs. Once you have inhaled, it is difficult to deliver it out. That's why a lot of our patients with obstructive lung disease, we teach them how to purse lip breathe. With restriction, it's a problem of compliance. Think of it like an elastic band na maganit, okay? And you have difficulty in expanding or pulling that elastic band. There is a problem with elasticity, compliance. The lungs have difficulty in expanding. And so, with restriction, there is an infiltrative problem also. And with obstructive lung diseases, there is small airway. The obstruction is in the small airways. There's small airway expiration obstruction. You may hear wheezing in these instances. You might find the presence of wheezing because of obstruction of the small airways. You may also see hyperexpansion on chest x-rays. So this means that there may be flattening of the diaphragmatic dome. There may be increased spaces between the ribs, the intercostal ribs. Okay, so the patient may be able to inhale, but they will have difficulty in exhaling the air. With restriction, there will be problems in compliance and reduced lung volume. The patient will have dyspnea and cyanosis, and there will be reduced gas transfer. And then on the x-ray, you may find ground glass appearances on the x-ray, the appearance of ground glass lesions on the x-ray. So going to obstructive pulmonary diseases like, for example, your COPD. Before, we used to describe COPD as emphysema, chronic bronchitis. Predominantly, when you're talking about COPD, you're talking about emphysema and chronic bronchitis. Of course, included in this obstruction COPD, we have emphysema, chronic bronchitis, asthma, and bronchiectasis. But why is it made into one term right now? Because we found out that a patient may have a combination of all of the symptoms of these diseases. So you may be COPD predominantly emphysematous or COPD predominantly with chronic bronchitis. So it's difficult to now label it just emphysema, chronic bronchitis, but people with COPD may have a combination of symptoms and signs from the different from these all of these different disease entities. So it's usually emphysema and chronic bronchitis are usually chronic in nature. So let's go on to the next slide. Discussing emphysema. This is emphysema is in the amalgamation of diseases known as COPD, and it is an end-stage lung disease. So different parts of your lung, your alveolar area, your terminal bronchioles will be affected. Usually it's the terminal bronchioles that are affected here in emphysema, and it may be centri-acinar in type, pan-acinar. Centri-acinar, usually it's the middle part that's affected. Pan-acinar, the entire area. And then paraseptal, and then you may have the irregular type. So there is progressive expiratory air trapping, and so that your patient may exhibit wheezing. Before, predominantly emphysematous patients, we call them pink puffers. And they usually did not exhibit the cyanosis because they were able to somehow compensate compared to your chronic bronchitis patients, which will have, they were known as the blue bloaters because cyanosis were more often present in cases like this. With emphysema like cirrhosis, it is thought of as an end stage of multiple chronic small airway obstructive etiologies, and it's non-specific. A lot of times we relate the cause of COPD in relation with smoking. But also, you can also have COPD without smoking. If you have a lack of an enzyme called alpha-1 antitrypsin, so people who lack this enzyme, this disease is called alpha-1 antitrypsin deficiency, they will experience COPD symptoms without being a smoker. And this is usually familial in nature, the alpha-1 antitrypsin deficiency. So can you be a COPD patient without being a smoker? Yes, you can be. But most often than not, COPD can be a sequelae of people who have been smoking for a long time. And even though they stop smoking, for example, they smoked, 20 years ago, they stopped smoking. They were chain smokers. They were having 1 pack a day for how many years? And they stopped. They may not exhibit the disease, maybe in middle age, in their 40s or 50s. But later on in life, during the time that they're older, maybe in their 60s, they may exhibit COPD already because the damage has been done due to smoking. But still, we consider that the etiology is non-specific, but COPD as a rule has been linked to smoking. And of course, we have also documented that alpha-1 antitrypsin deficiency enzyme will also cause COPD, and this is familial in nature. So there is increased crepitance in emphysema, and there is the presence of bullae or blebs. So these are like air-filled pockets. And the problem with these blebs is that once they rupture, one of the complications is pneumothorax. This is clinically likely, emphysema is clinically likely to produce recurrent pneumonias and progressive failure. So I want to show you the different types of what happens in the terminal bronchioles. So you have a centroacinar lesion, it's smack in the middle, versus your panacinar, which is, as it denotes, it's the entire area. It's the entire thing. Whereas here, you only had the middle area that was having difficulties. Okay. So obviously, the panacinar would be a bigger lesion. And this is the area of your terminal bronchioles. So this is an example of blebs that you may see. We have a gross picture of a bleb. Here you have, I was telling you these are pocket filled with air, as you can see. And then this is how it appears. This is how it appears on X-ray and on CT scan. See? And one of the things here is that when this ruptures, this can develop into pneumothorax. So patients like this, there are some things that you tell them not to do. One is fly in an airplane because it may rupture while you're in the air. Going in high altitudes. So even going, for example, a place like Baguio. And activities like even scuba diving, things like this, that will change your atmospheric pressure, that will change the altitude, may enhance the rupture of these blebs. So we're looking now at an X-ray of a COPD patient. Okay, so usually in patients, you will have hyperexpansion of the lung. And this will have a blunted or flattened hemidiaphragm. So this X-ray is actually an X-ray of a female. As you can see here, you have your breast shadow. This is the breast shadow. This is the breast of the woman. Okay. And then you have here the diaphragm. Okay, and the right side is not too flattened, no, but on the left it's a bit flattened. And you have increased lucency, and you may have the presence of bullae. And then you may have increased intercostal space. Okay, so you can see something here. Okay, I'm gonna stop share for a while because this yellow thing keeps appearing on my screen. Okay. Okay. So let's now go to chronic bronchitis. Okay. With chronic bronchitis, it can be caused by inhalants, pollution, again, cigarettes, and there is usually chronic cough. So this is a chronic cough which will occur yearly, maybe 3 months of the year for 2 consecutive years. Before, it used to be 3 months for 3 consecutive years. Now it's 3 months in 2 consecutive years. And it can often progress into emphysema. The patient will present with mucus hypersecretion, and they may have exhibition of wheezing, and they may exhibit some form of cyanosis. They have difficulty in expelling air. So you have to teach them how to do pursed lip breathing like this. Slowly exhaling. And then they have chronic inflammatory infiltrates. If you look at what is going on, what's going on microscopically, the mucus hypersecretion, there is increased goblet cells. Now let's go to asthma. This is similar to chronic bronchitis, but wheezing is a hallmark. And it can be caused by bronchospasm. So asthmatics usually suffer from bronchospasm, and this may cause wheezing. But let me reiterate that not all asthma attacks will exhibit wheezing. In fact, if it is a silent type, in other words, you cannot hear any breath sounds, you cannot hear any wheezing, that proposes more danger to your patient, because it means that the bronchospasm, the edema of the airways, is so severe that no air can come in or come out. So if you can hear the wheezing, there is some exchange of air, but there is edema, there is bronchospasm present. So if you were to give, for example, a patient with, you can hear hardly any air breaths, you can hardly hear any exchange of air on auscultation, any breath sounds, and you were to give, for example, some form of nebulization, or you gave some epinephrine, to release the bronchospasm, or you gave some terbutaline, and then after you were able to hear some wheezing after, that is already an improvement. That's not it. That's not the asthma becoming worse. That's the asthma becoming better. And then, of course, you have to stabilize this patient. There's a strong allergic role related to asthma. There may be increased in eosinophils, IgE, and of course, increased IgE and eosinophils are related to allergens, to increased allergens. This often starts in childhood, so it could be atopic or allergic or non-atopic in related to infection. Infection can actually also trigger asthma. The common cold can trigger asthma. So in children or in adults, it's very common that they will have the cold and then later on develop asthma. So there is chronic small airway obstruction and infection. The small airways are affected here. There is mucus hypersecretion with plugging, and there is the presence of lymphocytes and eosinophils. The lumen is narrowed and there may be edema and smooth muscle hypertrophy. So this is a sample of that, of hypertrophy. Okay. So these are classical findings that you would find microscopically with asthma. The mucus pluggings, presence of eosinophils, and there is edema, presence of edema, and the smooth muscle, problems with the smooth muscle. Okay. Now going to bronchiectasis, there is dilatation of the bronchus associated with often necrotizing inflammation. and it can be congenital and caused, but very often it's also caused by infective causes like TB, bacteria, viruses. So there is bronchial obstruction of the large airway, not the small airway. And it can also be related to rheumatoid arthritis, systemic lupus erythematosus, inflammatory bowel disease, or your IBD. So this is an example grossly of what you will find in bronchiectasis. Okay. So now we're going to go to restrictive infiltrative pulmonary diseases. Okay. So everyone, before we proceed off to the next topic, let's take a 10-minute break, please. And then we will proceed to the next topic.